Dr. Rinesh Chetty. We're going to talk about the good, the bad, and the ugly. I don't know whether it's the movie or whether it's what we're going to talk about. But basically, Dr. Chetty is a practicing orthopedic spinal surgeon. He's based at City Hospital in Durban. Before qualifying as an orthopedic surgeon, he worked as a forensic practitioner in Hampshire, in the UK, and also at the University Hospital of Wales Accident and Emergency Unit. He's a lecturer, undergraduate and postgraduate clinical skilled instructor based at the University of KZN Medical School. He's on the executive board of the Joint Medical Holdings Hospital Group and the executive committee of the KZN Specialist Network. And he regularly consults and advises on civil as well as criminal medical negligence cases as a medical negligence investigator for either party. So if you have any problems, he's a useful resource to contact with. I just want to read the last part of his CV, something about sports. He takes part in a lot of sports, but his biggest problem is that he can't beat his wife at tennis. So he's taken a paddle instead. Dr. Rinesh Chetty.
Thanks, Dr. So, it's always, I always get asked to give these talks, and when Mohammed asked me to give this talk, whenever I do one of these, I like to move away from the didactic, generic things about medical legal issues, because we all know about concept, documentation, it's pretty thing, but the main thing is, can you get my slides up? Are they up? Can you see my handsome face? Okay. So, you only really know what happens behind the scenes or in front of the scenes or anything beyond the scenes is when it starts happening to you. And I really consult and I deal with doctors that have gone through this process. And my experience is personal because I've been through this process, so I'm going through this process. So a lot of this talk is based on how I picked up things and it's sort of survival tips that I can give to all three parties. So when we talk about the good, the bad, and the ugly, and it's basically a moral judgment if anybody's ever watched the movie, and it's the fact that there's a fine line of moral ambiguity that's within all of us. We all have the ability to be good, bad, or ugly. And when we get a complaint, it's often much more grey than it being black or white. And I always say there's three sides to the story when you read a complaint. The complainant or the patient, etc., the doctor, the healthcare worker's response, and then actually what did happen. Because it all is very grey. And it's understanding that grey is where it's important for us to actually understand the principles behind what we're dealing with, especially when we're trying to police it. So the good, the bad, and ugly, once again, it's that moral ambiguity and the fact that the lines of good and evil are often blurred. And it's often that self-interest that drives us onto whether we want to push into which direction it is. And in essence, it's about the survival. If you watch a movie, it's about the survival in a war-torn landscape. So let me tell you, when it comes to judging medical error and negligence, it is morally ambiguous. And we are living in the Wild West. Because if you look at what's happening now, a profession is caught and with this fight for survival. We all know that, Prof. Parag mentioned about the exploding complaints of HPCSA, exploding litigation, healthcare worker abuse. It's never been worse. We thought COVID would make us a bit more appreciable. It's worse. So what's the objectives of today? And I'm going to fly through because I know time is an issue with you guys. But defining medical error, medical negligence, this is something that I try to push through and that we're trying to deal with a lot of the medical experts that are going through the SAML course. There is a big difference between it, as well as the fact that we need to try and explain what a reasonable doctor is versus a responsible captain. And I'll chat about that just now, but clarifying ethical science of moral practice. Everybody uses ethics and morals very synonymously, but it's actually quite different. Even when you look at the HPCSA guidance on ethics, they're actually talking more about morals, and I'm going to show you why. So to judge objectively evidence-based medicine versus subjective social accepted logic, that's in essence what the policing unit or a regulatory unit should be doing. And when we talk about the Dunning medical experts and the Kruger legal practitioners, we'll chat about that just now. But what I've mixed up in this talk, and this is what I want you to take home with, are global survival tips on how to live in the Wild West. To understand that you are living in the Wild West. And when it comes to medical legal judgments, we literally are walking a fine line that can go good, bad, or ugly, with the drop of hat. So what is error versus negligence? And this is the definition that we use, or I use specifically, is when a practitioner follows reasonable evidence-based medicine, but something goes wrong. And that issue that's gone wrong is relating to the failure of the delivery, processing, or the system in itself, in which that reasonable treatment is put into. So you did everything right according to the textbook, but something went wrong, a complication occurred. So that would be a medical error. So what's the difference between medical negligence? Now, the difference is that you either didn't follow evidence-based medicine, you did something completely wrong, which makes you negligent anyway. But say, for example, you did do the evidence-based medicine, but your behavior was wrong. Basically, you acted irresponsibly because you were in charge and something went wrong. And as a result, the patient faced a negative outcome. So there's a two-level process when it comes to judging medical negligence per se. And how did I figure out these definitions? Was by doing the medical law certificate, SAML certificate, etc., etc. I was being litigated at that time, and I said, let me read into what's happening with regards to the logic and the basic medicine, and how can we science it out. So if you understand the difference between error and negligence, then you can understand whether your complaint, or whether that complainant or that response is negligence or error. So we're all going to start thinking along the same lines. So let's put it this way. We all know the reasonable doctor test. That's Goodwin's test. We all know that. The reasonable healthcare practitioner. I put doctor, but I'm talking to healthcare practitioners. Because it can be the greatest doctor, because nothing went bad. Patient improved with whatever you did, whether it was evidence-based or not, and you're the good doctor. So great. That's medicine. And that's how it works by design. Whether you did something right or wrong, and the patient got better, nobody complains, everybody's happy. That's by design. You're the good doctor. But say something went bad. You didn't follow the science, then you're the ugly doctor. That's what we call negligence. But if something went bad and you followed the science, then you can say, look, you were a reasonable doctor. You followed the science, but something went wrong, and that's where medical error comes in. So when something goes wrong, did the doctor follow the science or not? That is the first most key important question that you've got to ask yourself. Whether you're responding, judging, or whatever you're doing. And if not, if you didn't follow the science, then he's liable, or she's liable, and you've got to call your lawyer. So that's how you judge the science. That's the very first thing. We are scientists by trade. So how do you judge the law? And that's where you've got to start chatting about, because remember, it's a medical legal principle. It's a combined principle, not just the science. How do you judge the law? That's where we start talking about ethics versus morality and the judgment of medical negligence. Because what is ethics? Ethics is a logically objective. It's found in the textbook that you studied in medical school. And basically, it's your practice bound in scientific principles. Is it acceptable evidence-based treatment? And that's by your peer review. That's by the other person sitting next to you that studied the same thing, same qualifications. It's telling you, yes, it's correct. And that's how we judge science. So, morally obligated is what is instinctively subjective. It's what everybody here has within themselves. Because in the end of the day, is your practice based on fair, neutral, unbiased thoughts? Did you overservice the patient? Did you underservice the patient? Is it acceptable to society the way you behaved and how you treated that patient? That is how your conscience reviews it. I often say it's what you do when the cameras aren't watching. If you take your shopping cart to your car, offload your groceries, do you take it back and put it into the trolley bag, or do you just leave it on the side? But if you saw somebody watching, would you could do that? Your conscience review. And that's where the law fits in. So in essence, performing the procedure would be a reasonable action for the pathology is a correct clinical indication. I did a hip replacement in this patient because she had severe AVN and collapse of the hip. Great. But then I've got to ask myself, performing the procedure would be a responsible action for the patient. Is it morally correct in what I did? I did an operation for this patient, but she lives in a hut with a toilet outside with no help, tons of stairs, and nobody else to watch her. She went home, there was nobody else taking care of her. She fell, she broke the other hip, she got infected, sepsis, etc., etc. I should have thought about it morally before doing it, even though my textbook said that this X-ray looks like it needs a hip replacement. That's how I think of it in my head. That's how I try to explain it, because that's the science and that's the law. Now, ethical, morality, reasonable science, responsible actions by the law is how how we come up with the judgment. So your judgment can either be the good, the bad, and the ugly. So that's where my title comes from. So once again, we've been through this slide. So we know the science. So we know the science already. So in essence, if there was a medical error, we then ask ourselves what went wrong, who or what was responsible. And that's where the captain of the ship principle comes in. Because you are in essence the one in charge of that patient. So was your actions responsible or not? Because if your action, that's a moral question. If your action was responsible, then fair enough. If it wasn't, you've got to call your lawyer because you might be negligent, or you probably are, if you weren't responsible as the captain of that ship. And that's where the law comes in second. So in the HPCSA and all of them, I know it says I'm talking about the GMC, I'm talking about the American Association, the Egyptian Association. I've sort of picked up on all of them because I've gone and looked into how they work. And it's always a connection between doctors and lawyers. So once again, a doctor is an expert in science because he's objective or she's objective. An expert in the law is an expert in the law. It's a subjective thing. It's an opinion-based thing. Because in science, it's great. We could be the best doctor, the worst doctor. We could have a complication, and that's where the reasonable doctor comes in. In law, it's black and white. It's a binary process. According to the law, you are wrong or you are right. Now, you've got to understand the ethics because that's where evidence-based medicine comes in. That's where science comes in. But with lawyers, you've got to understand the morality, the opinion-based logic, because they work on precedents. So because this happened in this law, and the judge felt this way, if it happens again in another case, because that judge said it, that's what they're going to follow. Because that's the precedent that's been set. That's the differences. And this is why doctors guide the profession, and the lawyers protect the public. That's the way I see it. Because in essence, together they make a judgment. Now, Prof. Park has gone through the different complaints. The issue I want to look at, or the way I want to show you guys, is where it's important for you all to understand it. How does the complaint get from the complaint to whether it gets mediated, the penal meeting, formal inquiry, or a police case? Because that can happen. So I'm going to have a chat about the complaint, the complaints officer, the complaints investigator, and this thing called the summary, which is very important. In essence, like we talked about, as Prof. Park went through, dropped, warning, fine, charged, etc., etc. But have a look. The science is reviewed first with the law, then the science is judged in the penal committee, and then the law starts judging on what happens after that. So, important things that need to be made very clear is that during the complaints officer, complaints investigator, and summary, anything you give to the HPCSA can be used in a court. It's evidence. It can be used. Whatever you say to the HPCSA can be used. They say it to you. Okay? This is why we have insurance, and this is why we have lawyers. So in essence, when it comes to mediation, penal, formal inquiry, police case, etc., and you're judging the ethics, you wonder why you're having a mediation. Because mediation is without prejudice. I do mediations. Done a few, not a lot, because look, it doesn't happen that quite often because people don't understand the principles of mediation. It's a without prejudice, meaning whatever's said in that mediation can't be used in a court of law against you, and whatever's said there, it's basically to open communication. So ask yourself, why aren't we using it more often in the HPCSA? Because if it's a complaint against the patient with the practitioner, why doesn't the HPCSA mediate everything? Why do we get to choose the minor transmissions? I suspect that we should be using it more often. It's a powerful tool. And the Gauteng Law Department or the High Court has turned around and said every medical negligence case needs to be mediated first before it comes to the High Court. So I think we should start looking at that very carefully. Once again, survival tips here. The penal meeting, if you're found guilty, you can appeal, the doctor can appeal that, and if it's appealed, you can go to the formal inquiry. But what's interesting about that is that the patient gets to know what's said in that penal meeting, gets a response, whether you fine, dropped, or whatever. So in essence, even if you find, etc., it gets given to the public, it gets given, and members of the public are allowed to be there and allowed and get this information as well. If it goes to a formal inquiry, then basically a member of the public is part of the judgment committee. So besides the lawyers and things, then they get members of the public in there. So I'm also wondering what happens there, but when I get to that point, I'll let you guys know. The police cases that, they can go to the police case, and I'm going to show you guys who's in charge of getting the police involved if they're worried about that complaint. But in essence, when you get to these things, the way I see it is it's an expert in science and the law has to listen. When it comes to charging the patient, or the doctor, you can either drop that complaint. If the complaint's dropped, in whichever one of those things is, the patient can now appeal. So, which is, I think, is fair, because often what was happening was, you just get a letter if you complain about a practitioner or a complication, and then the HPCSA, we looked at it and we dropped it. And it often brought a lot of anger and distrust with the public. So now you give them a chance to appeal, which is good, but that's extra work now. So with the work that they have already, they've got more work now. You can get a warning, great, but once again, remember, whether it's a fine or whether you charge a warning, the patient gets a copy of that. And whatever you gave in evidence to the HPCSA can be used in court, as well as the minutes of the meeting is made available, which is also very strange, because when you get fined or you get cautioned, and you can choose to accept it and pay the fine, and nothing gets put into the HPCSA register. There's no thing on your name. But then you also aren't allowed to look at the minutes of your meeting. So in order for you to, say for example, if you are fined, say maximum fines for over-servicing or putting patients at risk, and you wonder, like, how did they get to that outcome? But you have to pay the fine, but you can't see the minutes. But if you don't pay the fine, you appeal, then you get the minutes. That's when you get to find out what happened in that meeting, which also doesn't make sense to me. But it's something that we need to look at. These are survival tips. Because when you get charged, it becomes a public thing. That's when you put on the internet and you go to the HPCSA, there's a log, your name comes up, your HPCSA number, everything you were charged with, and the fact that you were found guilty. That's all public. So it's adding to that. So then you're sort of stuck in the situation when you get a complaint. Do I just accept the fine and make it go away? And the thing is your insurances will actually offer that to you sometimes. To say, listen, pay the fine, make it go away, it's not going to affect you later. Darby van Niekerk or Van der Walt did that. He landed up in jail 7 months later, or for 7 months. He was the first gynecologist to get jailed for manslaughter. He paid the fine, thought it'll go away, and it didn't. It was used as part of evidence against him and went to criminal court. And his case got dropped because the magistrate decided to do her own research and all that, etc., etc. So the morality judgment and the fact that when you decided to get charged should be done by the lawyer and the science persons. So how do you get to that summary? Because that summary is key. And this is where I'm chatting to you about the complaints officer and the investigator. Because the qualifications are NFQ level 5 and 7 versus our qualifications at 8 and 10. So often I feel that if you're going to be investigating, it should be an NFQ level, or should be at least a doctor who's investigating a doctor, or doctors who's investigating doctors. But in this situation, there's a general complaints officer and investigator. And NFQ level 5 is what the complaints officer is, and that's 6 months out of the matric. NFQ level 7 is a bachelor degree. So it could be a P-Tech, could be an optometrist, could be a registered nurse and things like that. So those are the ones that are in charge of complaints arraignment or organization and then investigation before they make a summary, which is then used in your criminal meeting. So the understanding behind the science law and evidence, checking timelines and things, we put a lot of trust in these specific people that work for our policing body. The abilities to analyze the facts from the fiction. It's very difficult to understand that because the responsibilities of these people are very important. And because they decide to refer, drop, mediate, or send to the pleader or call the police. So that NFQ level, we start thinking about it. Are they really able to do that? Are they qualified for that? Is there a way to challenge that? Because they create a summary of the complaint and the response. And this is another survival tip to understand, is that the complaint is written as a layman. So it's somebody of the thing that's writing it as a layman that's giving it to an NFQ level 5 and 7. And it's easy for them to understand. But our complaints are scientific and legal complaints. So we give scientific evidence to our lawyers, who then create a legal response. So there's 2 levels of complexity in our response, given to an NFQ level 5 and 7 to differentiate and create that summary. There's a lot of trust in that process that it's being done correctly. And you know, this is where I got the evidence from LinkedIn and the fact that it's posted up. But as you can see, NFQ level 7, NFQ level 5, and their main jobs is if there's something really dangerous, they are the ones that have to inform the police. So we really need to improve that level of interpretation and scientific evaluation preliminary first off. Because what happens, how many of these get missed? If you've got a really dangerous practitioner, are they recognizing it? Are they sending it across? And is it a process that is available, or is it a process that they are qualified to do and willing to do or do it efficiently? Is it because it's a complex process and needs to be done quickly? So maybe that's a survival tip. So the summary is key in the prelim meeting because it's used as a baseline to set the science, the scene and the tone of your prelim meeting. And in the prelim meeting, you have one medical expert that everybody must trust that he's the expert or she's the expert. Because in that meeting you are judged, you have the jury, and you can be executed. They can decide what to do. So be clear in your response, and this is a survival tip. It's a way in which I've changed when we respond to the HPCSA via ethical, Genoa, or MPS, and we've sat down and we've gone through it and we've changed it. Because I'm trying to cut down the legal jargon and the medical jargon and make it as layman as possible because we know who's reading it. Because remember, the complaint is a basic review. That's why when you look at these summaries, the complaint's written as a lovely little story, but the practitioner's complaint or the respondent's complaint is often not the case. The response to the claimant, it's a legally interpreted medical language and it can be so complex. Are they doing it carefully? There's a lot of trust input here. So the respondents must take this into account so when you get your MPS or your ethical response or you're about to respond if you're not unsure, write it as simple as possible to make sure that your science, your morals and your ethics are proved so that you can defend yourself and get your side of the story heard. Survival tip. Medical experts, now we've got a big problem with this, and I think maybe it's a problem across the board because we have major issues. It's a global challenge, and often what's happening is age, continued medical education, and the badge that they wear that are making them experts, and we have a big problem. If any of you guys have dealt with experts in the court or with medical experts, there's a big problem at the moment, and we're trying to change it. What are the biggest problems? The biggest problems I have with some experts is that most of them haven't read the documentation that was given to them. There's a pack. The response needs to be read. A lot of them rely on the summary itself because in essence, what are they asking? They're asking whether this was a medical error or medical negligence. It's what the lawyers are asking you. Was the science correct? Was it ethical? Did the doctor act responsibly? And this is the problem. It changes. It gets blurred along those lines. So is there an overview process? Is there consequences for poor performance? Do we complain about it? We can't really because in essence, the HPCSA is our policing body. And this is where the Dunning-Kruger effect comes in. Because the biggest problem with medical experts at the moment is that you actually have a cognitive bias where you overestimate your competence. And the fact that you might not be the most expert in what you are dealing with, but the fact that you are the loudest person in the room, the most connected with regards to and you've been given that role, that you feel that you need to act in that role. So in essence, there's a lack of self-assessment. That you can't look yourself in the mirror and say, listen, I shouldn't be dealing or shouldn't be judging with this. And this is the problem when it comes to medical experts. Because they are told they're experts, they start behaving like experts, they start talking confidently, and in essence, they don't do their job correctly. But you can't tell them that. Because there is no self-assessment. And the first rule of the Kruger-Dunning is that you don't know that you're part of that club. So they really don't understand, and they have to understand the competence behind it. And sometimes they do know. And we find this in private cases as well, where it's an intentional ignorance and naivety. And that's when we talk about the high income. So medicine and law is aware, and this is a survival tip to the experts out there that aren't following the science or morals and ethics. Justice is coming because the experts are aware, and the law is aware, and the judges are aware. So as much as it used to be you talk, and because you talk and you're covered by expert protection and things, that's changing. It's changed globally. So legal practitioners, there's been a lot of amendments to the HPCSA because they're trying to speed up the process by cutting down the time, allowing us to use Zoom, which is excellent, and then they've allowed the patient to have an appeal, which is good. But the thing is, you've got to follow those things. We've got doctors waiting for inquiries where they're told they've got 60 to 90 days. They've been waiting 4 or 5 years now. So they're trying to fix up the process, but they need to speed it up. How they do that? Survival tips. Everyone must respect that preliminary process, including the people that are part of that meeting. If you are spending 8 to 9 to 10 hours working on a response to give to the HPCSA, the least they can do is respect your response and read it and take the time. Sometimes it can take 7 minutes and 7 words from an expert that turns around and judges you and puts you in a corner and tells you that you're a bad professional, but yet nobody read that documentation, and the only time you'll know that is when you ask for the minutes and you get the recording, and that you get a week before you acquire it. Is there an overview process? Is there a self-assessment? What are the consequences for poor performance? How do you complain about this process if you've been judged already? There is no complaints process to be put forward. So how is there self-assessment being done? Because what's happening at the moment, why do we need this? Healthcare at the moment is the Wild West. Exploding litigation. Look at the amount of workplace-related violence and how it's going on. Everybody knows it. A gynecologist had a face smashed in Shifa a couple of years ago. Not much came about that. But I mean, at the end of the day, there's a vicious cycle because there's this increase in litigation costs. It's costing services. We can't employ doctors. We're providing defensive medicine. And it's angering the families. Dr. Abdullah Munshi's wife calls me every day on his anniversary of his murder. I don't have answers for her. Who does? Who knows? Social media, social judgments, whether it's in mainstream media or social, I think they're both the same. They're both looking for clicks, they're both looking for drama. Anything to do with doctors, healthcare workers is the biggest problem. It's a danger to healthcare workers, it's a danger to the public, because how do we assess whether this doctor is ethical or moral, and we need to do it efficiently, we need to get him off the line, if he is. It's an endangering the profession. This is why there's burnout. This is why the healthcare workers' abuse is occurring. And what's worse is we're not learning from our errors because we try to either hide them or not put them across. Because if we do, we get litigated. And this is why we need a working HPCSA. We need to break that cycle. The HPCSA is key. If you can get speed and efficiency to answer those questions, it's key. You can really sort out what needs to happen. Because at the end of the day, if we can break it, we can science it out first. So we can look at those prelim meetings, we can evaluate those investigations, do all the things that are necessary. We can really improve the HPCSA to a point where they can answer the questions and they can provide problems to patients and complainants so that they can cut that anger down. Lawyers bounce the ideas of the HPCSA, and if we bounce it and bounce it back to them, we can cut down frivolous litigation. If you have a problem with the HPCSA, the only chance you have is to go to the High Court. And if you have to go to the High Court, you've got to wait for the whole process to finish up. So there's nothing in between for you to do. And it's almost like a double jeopardy because you've got to pay for the High Court. So you can wait for the HPCA to finish up what they need to do and then go to the High Court. But is there a self-assessment tool? Is there a way to say, listen, we're complaining about this, about what happened. The lawyers will tell you there's nothing, we just got to wait for the High Court. It's not really fair. So improving the science, streamlining the legal process, and mediating the errors is key. Because it's a global problem. It's not just the HPCSA, it's the British Medical Association, the American Medical Association, Egypt, Argentina, all have had major issues. Medical error mediation is a powerful tool because you can say what you need to say to the patient and you bring them back to the table to communicate. And it's a survival tool because its speed, cost, and its confidentiality is key. If you don't understand it, do the course. It's a wonderful way to open up and understand what to do because we need organizations like the Islamic Muslim Association to have their own mediation committee. If there's a patient that's complaining, the IMA has their own mediation committee. The patient can come through the IMA and we facilitate that. It costs nothing. But it speeds up and opens a line of communication. It brings back the doctor to a patient-doctor relationship with trust. Because as much as, I'm flying through the slides, I know my time's almost up, but as much as the guidelines of the HPCSA is to guide the profession and protect the public, that's the legal service. Our scientific service or healthcare service is to protect the profession and guide the public. So in summary, never give up and never surrender, especially if you follow the science, and especially if you captain your ship. Respond appropriately and know your audience, know who you're talking to. Prepare for the worst and hope for the best, unfortunately, because remember, this is the Wild West until it changes. Keep learning. If you have a medical error in your system, fix it, because that's what we do to improve the system. we are the captains of the ship. We are ultimately responsible because that's your duty. If you accept medical negligence, reform. And experts need to be that. The organization like the IMA, with their massive multidisciplinary pool, I deal with the KZN specialists. You guys can create expert opinions through your organization, and you can utilize it. And the HPCSA and the organizations can do all that as well. So organizations have got their own committees, they have their own AGMs, they're perfect, they're organized and well-resourced brains that can help you with experts. So if you need an expert opinion, consider doing that as part of your AGM or as part of your committee. Create an expert opinion board, mediation board, medical legal assistance. And imagine, you guys have got a perfect thing. It's multidisciplinary. You can get an intensivist, a physician, and a surgeon to give you an expert opinion. It's something that's being underutilized by everyone. Survival topic. Any references, guys? I'm not an academic. I'm a clinical doctor. You guys know me. Send me lots of patients. Thanks. My Essay Doctors United page is a Facebook page, and I put all my references. Everything I read up on is there. It's my thing. And then the other one, can you bring that slide, buddy? An important one there. Yeah. The LinkedIn page is where I put up all my medical, legal stuff and clinical stuff. But that was the thing when Professor Beale and Dr. Munshi were arrested. And I started that petition, and we had over 86,000, 90,000 people sign it. I recognize quite a few of the names on that petition. I'm keeping that going. I'm keeping it going because I want there to be some answers for Dr. Munshi. And I'm going to keep that petition open until we get there. And until we start protecting our profession and guiding it, I think we've got a lot of work to do. So in final, thank you for your time, guys. Thank you for your time, captains. And stay safe and stay united.